Thank you. Really.
Mehul, it's 5 o'clock. You can make it live and we will start. I'm just calling Madhuri ma'am to see if she's joining in right now. Mehul ji?
Yes, ma'am, I am going.
Yeah, you can go live and we
Yeah.
start sharp on time.
Yeah. So it is live.
Yeah, you may start.
Just
Welcome, Madhuri ma'am.
Hello, how are you? I hope
All
I'm
good,
in
ma'am.
time. I hope I'm
Yes, ma'am. Just in time. I was giving you a call and you logged
I
in.
know, it was not getting connected because I was
Namaste,
trying
sir.
on my laptop. Then I said, let me join on the mobile.
Evening, madam.
Mehul, start.
Hi.
नमस्कार माधुरी जी.
नमस्ते, नमस्ते.
नमस्ते. कैसे हैं?
बस मजे में. अरे वाह.
ma'am, can we start now?
Yes, please.
So, good evening, all the faculties and delegates for the SearchLite 20 webinar, Corconnect live webinar, which is on the topic of the third trimester scan. And this webinar is initiated by Dr. Asha Jain, Cancer Prevention Relief Society. She is a medical director of Cancer Prevention Relief Society in association with Karnal, Karur, Kasargod, Kashipur, Kolhapur, Kolam, Kota, and Bhimavaram Obs and Gynae Society. So, first of all, it's my pleasure to invite our convener, Dr. Sujeshri Sangeeta. Sujeshri ma'am is the founder secretary of Bhimavaram Obs and Gynae Society, as well as she is as a consultant of ops and laparoscopic surgeon at Seshadri Hospital. And madam having the interest of laparoscopy and infertility and achieved so many awards and also done paper presentation in various conferences. And madam is conducting the awareness program Vikasam for the adolescents girl. So madam, over to you.
Thank you, Mr. Mehul, for those kind words of introduction. So taking the program forward, I would like to introduce our program director, Dr. Asha Jain, ma'am. I'm sure she needs no introduction, but then proceeding with the same, right now, madam is the director of SMSA Hospital, Raipur. She's also the medical director of CPRS. She's the elected member of CG Medical Council, zonal chair, Foxy Food Drug and Medical Committee with West Zone. She's also the chairman of Mission Pink Health, IMA Raipur. She's the executive member of ISCCP and also CG ISAR and CG SFM. Her past offices which she's held is she has been the president of Raipur OB-GYN Society. She has been the vice president of IMA Chhattisgarh. She's also been the president of Rotary Club of Raipur North. So madam has received training in colposcopy. She's also an instructor in FCCS OB course. She has received IOTA certification and her fields of interest are saving the uterus, fetal medicine, critical care, preventive oncology and colposcopy. So welcome to today's program, ma'am. And I request you to please take over.
Thank you, Dr. Sujeshri. I welcome all the dignitaries to this program. And before we start the program proper, we pray for the blessings of the divine before we take the program forward. So just a minute of pranam to the divine.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा. ॐ
Namaskar. Welcome to this 20th webinar of the SearchLite series. SearchLite is basically a series which is focused on one particular topic which needs a little more attention from us. So things that are in the dark are lighted up. Therefore, the name the SearchLite. This time, Karnal, Karur, Kasargod, Kashipur, Kolhapur, Kollam, Kota, and Bhimavaram societies have joined us. I welcome our chief guest, Dr. Madhuri Patel ma'am, who's the Secretary General of FOXY, who has come to this program today. I also welcome Dr. Leela Vyas ma'am, past VP FOXY, and Dr. Sita Ramamurthy Pal ma'am, who's the Genetic and Fetal Medicine Committee chairperson. I welcome the convener, Dr. Sujeshri. I also welcome all our chairpersons, Dr. Kaushalya K, Dr. Vidya Nambiar, Dr. Reena Singhal, Dr. Ansi Jacob, and the speaker, Dr. Chanchal ma'am, who agreed to speak on a topic from a gynecologist point of view with a very short notice. I also welcome the second speaker, Dr. Chandar Lulla sir, who will be speaking on anomalies that are detected late in pregnancy, and Dr. Prasad Halkarnikar, Dr. Annamma Mohan, and Dr. Ritika Mathur as chairpersons for the second program. I welcome Dr. Purvi Agrawal, executive member of SFM Chhattisgarh, who joined in as an expert, and Dr. Priyanka Memani, Dr. M. Malini, Dr. Meenakshi Agrawal, Dr. Lakshmi Pai, Dr. Indraneel Jadhav, Dr. Khushbu Meena, Dr. Priya Gupta, Dr. Neha Sehra, and Dr. Bharti Gahatori, who are joining us as panelists. I welcome all of you, and I hope this SearchLite today will give us a new insight into the topic, and we will be able to interpret the reports that we get of the third trimester scan better. Also, our counseling to our patients would be better. That is the plan for today. Thank you so much for being here. May I have the CV of Madhuri ma'am? I would like to introduce Dr. Madhuri Patel ma'am, who's the Secretary General of FOXY, Editor-in-Chief of Jogi. She was Joint Secretary FOXY in 2009, Committee Member FIGO Preterm Birth, Honorary Clinical Associate at Wadia Hospital, Parel, Mumbai, Honorary Consultant Police Hospital, Mumbai, Visiting Consultant St. Elizabeth Hospitals, Mumbai, former Professor and HOD Gynae, ESIC PGI MSR.
Thank you, Dr. Asha. Thank you.
Welcome, Dr. Madhuri ma'am. Everybody knows you, but it was just reminding myself of all your achievements. So over to you, please.
Thank you, Dr. Asha, for your kind and warm words. So respected our project director, Dr. Asha Jain, and our all President Secretary of Karnal, Karur, Kasargod, Kashipur, Kolhapur,
Ma'am, you got muted.
Madam, you're muted.
Madhuri ma'am, you're muted.
You need to call her, I think. Madam, you're muted.
Ma'am, I think you should call her, ma'am. Dr. Asha, ma'am.
She has logged in from her mobile. So,
can you hear me?
Yeah, now we can hear you.
Yeah. So, and of course, I have my committee chair, Dr. Sita, doing excellent work in the genetic, chromosomal anomalies. And I'm very impressed by her work on especially Down syndrome once the babies are, born, what to do. And of course, we have all our excellent speakers today. And, Dr. Chanchal, who is going to talk on guidelines for third trimester scan. Because many times, we just carry out the third trimester scan for the growth, fetal growth. But along with that, as it is rightly put, that interval growth is important, the fetal well-being is also important. And, there are many things, amniotic fluid, placental, circulation, Doppler, all we do routinely. And Dr. Chandra Lulla is going to talk on the third trimester anatomical defect, congenital malformation, which is not acceptable by many of our patients because, second trimester, when a malformation scan, then 2D
I
echo,
menopause
24 weeks. Then still, if you find in the late trimester, malformation, the patient do not accept. I remember one of my patient was diagnosed in the third trimester with congenital diaphragmatic hernia. And she was so upset that she was lost for follow-up. So there are certain things which are not our control, but there are certain things which in our control we can definitely counsel our parents for the best to our babies. And of course, we have to also look for each and everything, delivering of the baby, amniotic fluid, cord around the neck, which will also, lie, malposition. I will say malposition is also very important. That is occipital posterior. That will also give us idea on third trimester sonography. And all these things put together, we will definitely have better outcome as far as the fetus is concerned, perinatal is concerned, as far as mother is concerned. And so we have excellent chairperson, we have excellent panelists. I'm not going to name because Dr. Asha has already named. And all my dear friends, please enjoy this, webinar and learn, many things. Because I would like to quote, Benjamin Franklin, that in knowledge, if you knowledge, your investment in the knowledge gives the best interest. So we should always invest ourselves in updating the knowledge and give the best to our patient. And I would like to add one thing about Dr. Chandalula. He's a famous internationally and nationally. Even though he's a radiologist, he's famous amongst our obstetricians. And without him, when we are in Mumbai, we don't go ahead with the other sonologists. So he has that, name, and we trust him for each and everything. So Dr. Chandalula, welcome for this webinar. And thank you once again, Dr. Asha and team, Dr. Sangeeta, for giving me this opportunity. Thank you very much.
Thank you so much, Dr. Madhuri. Out of your busy schedule and just in between lectures, you have spared time for us. Thank you so much. Thank you.
Okay, thank you.
Now, I would like to introduce Dr. Leela Vyas ma'am, former senior professor and unit head, IVF consultant, member of Research Review Board, SMS Medical College, Jaipur. She is the Director, Department of Gynae, Hope Hospitals, Jaipur, Senior Consultant, Cocoon Hospital, Director, Aesthetic and Cosmetic Gynecology, Vyas Clinic, Jaipur, and she is a mentor for Dakshata Lakshya at NHM Rajasthan. Director Manyata also. She has been VP Foxy 2018, Founder VP INSARG 2023, Chairperson ISAR Rajasthan. Welcome, ma'am. Welcome so much.
Thank you. Thank you very much.
President Narchi, President Jaipur Society and Secretary Jaipur.
Okay.
Over to you, ma'am.
So good evening, everyone. And thank you very much, Asha, for calling for this. I would like to say a very useful session. We always talk about first trimester, second trimester and all. And a really good evening to Dr. Madhuri. Madhuri is, everyone knows, Secretary General, and she always takes out time from her busy schedule and coming everywhere. Sita, my another friend, she is one of the fetal medicine. And then your team, that everyone is there, Dr. Sangeeta, who is the convener of that, and the all society secretaries and president. Yes, I'm not wasting time in taking this short time is there. We just so the societies which are the Karnal, Kannur, Kasoda, Kashipur, Kolhapur, Kolam, Kota, and Bhimavaram, Ops and Gynae Society. These are there. So I think I'm finding that Kota is from near to me. I mean, basically I'm from Kota. Karnal, again, it comes in the north. Kashipur, again, this. So these are in our zone. That is, we are as such in the west. Rajasthan is there, but more of the culture is of a north one. So always the patients, when they are coming to us, first thing you send for the sonography, the mother-in-law will ask that, अब कितनी सोनोग्राफी आप लोग कराएंगे? then it comes from us that we say no. One is the dating sonography, then NT scan होगा और उसके बाद में anomaly scan है उसमें, then they ask what you are going to do, and then we say that we'll go with the growth scan. But we never explain them that there are some anomalies which can come appears later, and this is one of a big group of problems associated with the doctor and patient, because patient thinks of that once you have done anomaly scan, you have said that yes, everything is okay, there's it will go wrong, because the patient on the every time the mother-in-law and mother they are coming, sab kuch theek to hai na, sab kuch theek to hai na, then we always say that no, we will do a means routine checkup we are doing with the sonography, and we will look for the each and everything there. Then their question comes कि जब हम मैडम आपको दिखा ही रहे हैं तो फिर गलत कैसे जाएगा? So this is not, as Dr. Madhuri has very rightly said, that something is not in our hand, which will be there, we will see that and we will answer them. So choosing this topic, definitely it is a very important thing. And then Dr. Chanchal, who is going to speak on the guidelines. Yes, that guidelines, if everyone should know it, then accordingly we go, so we can be prevent us from the litigations which we are facing, that आपके पास आए थे लास्ट में हमारा सब कुछ था, even for the oligohydramnios we are blamed that कि मैडम आपने पहले क्यों नहीं बताया. So we always show them कि पहले ऐसा चल रहा था, अब ये ऐसा चल रहा है. And as Dr. Lula, expert, he is sitting there, he is going to explain each and every thing which is to be seen in the third trimester, and we can save ourselves. So thank you very much, and again in advance congratulations for conducting this type all CMEs to benefit our all Foxy members. And Asha, wishing you all the best for your future endeavors. Thank you very much.
Thank you, ma'am. Thank you so much. Now, it is my pleasure to introduce Dr. Sita Ramamurthy Pal, another person who doesn't need an introduction, known to every member of Foxy, consultant fetal medicine and obstetrics at Apollo Multispecialty Hospital, Ankuran IVF and Fetal Medicine Center, Institute of Fetal Medicine, Kolkata. She is the honorary treasurer of Bengal Obstetric Gynec Society, chairperson Genetics and Fetal Medicine Committee, Foxy, President Society of Fetal Medicine.
I'm waiting myself to hear the talks from Dr. Lula and Dr. Chanchal.
Thank you so much. Thank you.
Time in this. So firstly, thank you. It's my privilege and honor to be a guest of honor in one of your SearchLite series. I like the name, and in fact, I have been following some of your sessions, which on ultrasound, especially on fetal medicine, that you've had earlier. So they've been really wonderful and very informative. So congratulations on that. And I like your idea of involving societies from K to K, like Kashmir to Kanyakumari. So you've involved all of them. So I'm looking forward to that. Greetings to Dr. Madhuri ma'am for joining here. And as Dr. Leela said, she never misses an webinar to attend. That's very inspiring. And you've got wonderful speakers. This very important theme that you've taken on third trimester. So because gone are the days where we've restricted ourselves to second trimester, and I think we know we need to do a scan in the third trimester. And I think Dr. Chanchal was a good friend of mine. She will elaborate on the recent guidelines as to when it has to be done. One is enough at 32, 36, and what are we going to look at? And as I always said, whatever we do in the second trimester, as Dr. Leela has also put it, some of the anomalies are the evolving anomalies which might develop later on. So the patients need to be counseled accordingly. And then it is also to pick up the late onset FGRs that we might miss, which might not be picked up earlier. And of course, Dr. Lula, who's been our inspiration and guide for all of us in the fetal medicine specialty. Every growth scan nowadays every anatomy scan becomes a growth scan, and every growth scan becomes an anatomy scan. So we still have to look at every organ in details, be it developing anomaly because of the physiology of the development of the fetus, or some ones which may have been missed even if it's normal. So it's important to store your images in the second trimester as well, and third trimester to see. So looking forward to these two wonderful lectures and your wonderful panel with all the faculty. So thank you once again for inviting me, and wishing you all the best for your series and for your future endeavors. Thank you once again. Thank you.
Thank you so much. Thank you. So With that, we come to the end of our inaugural session. We have received blessings from Madhuri ma'am, Leela ma'am, and Dr. Sita. And over to you, Dr. Sujaya, to start this.
Moving forward to the first session, which is guidelines for the third trimester scan. I would firstly like to introduce the chairpersons for this session. So we have Dr. Kausalya, who's the president of Karur OB-GYN Society. Madam has completed her MBBS from Coimbatore Medical College and DGO from Madras Medical College. She's a consultant gynecologist at Kabila Hospital. Welcome, ma'am. We have Dr. Vidya Nambiar with us. Madam is the president of Kasargod OB-GYN Society. She's a consultant at Krishna Hospital and Janardhan Hospital, Kasargod. Welcome to today's session, ma'am. Lastly, we have Dr. Reena Singhal with us. She's the president of Kashipur OB-GYN Society. I welcome ma'am to today's session. We also have Dr. Ansi Jacob with us. She is a consultant gynec endoscopic surgeon, professor in obstetrics and gynecology, Travancore Medicity, Kollam. Her areas of interest and specialization are gynec endoscopy, trained in gynec endoscopy under Professor Von Herendal. I hope I got the name right. And she has several publications in International Index Journal. So welcome to today's session, ma'am. I would request Dr. Ansi Jacob to please introduce the speaker for today's talk. Dr. Chanchal.
Thank you so much for that introduction. Without any waste of time, I would like to invite the speaker, Dr. Chanchal. She is specialized in fetal medicine with a fellowship from Singapore, and she is a lead consultant working in the Madhukar Rainbow Children's Hospital. And her areas of interest is, of course, obviously, it is antenatal screening with high-risk pregnancy, especially fetal growth restriction. She got a lot of academic activities, and she is a current member and a past chairperson of the Fetal Medicine Genetics Subcommittee. I think I invite Dr. Chanchal for the session. We are all eagerly waiting to hear what you have to say about the guidelines. Every time being the obstetrician, we face the dilemma whether we should go for third trimester, and we go for the routine third trimester scan, but still some people ask, why should we go for that? What are the consensus? Is it a must to do? So to answer all this and all our queries, we have Dr. Chanchal. Please, over to you.
Thank you for the kind introduction. First of all, thank you, Dr. Asha, for giving me the opportunity to be with everyone here. So I've been asked, so I think the stage has been set with with the previous speakers highlighting how important and how scary it is to be in a situation where we find a problem in the third trimester, especially when patients come up with the statement that we've been seeing you right from the beginning. So I would, I'm going to share my screen. So guidelines for the third trimester ultrasound. This guideline, which is the most recent guideline issued by the International Society of Ultrasound in Obstetrics and Gynecology, it is freely available online. So I would encourage everyone to go through this guideline. It has been made very exhaustively, and it gives the current evidence. The answer to your question, and see, still, except for ISWA, we do not have standard guidelines although there is so much of evidence. And I think we will be able to incorporate it in our algorithms. There's still no consensus as to in most of the OBGYN bodies that we must offer a third trimester ultrasound. We in fetal medicine feel we must, and this guideline endorses that view. And I think by the end of this session, at least we will be able to convince people that it is important to do a third trimester ultrasound. And as Dr. Sita said, every scan is an anomaly scan, which Dr. Lula will highlight in his talk. So what are the objectives of a third trimester ultrasound? We want to assess viability. We want to assess fetal presentation. We want to assess the anatomy. We want to assess the growth, the amniotic fluid volume, the placental localization, and fetal placental Dopplers. So I'm going to talk about the last four because anatomy will be covered by Dr. Chandalula. And what are the common indications? When do we ask patients to get a third trimester ultrasound. When there is a query regarding the gestation, when patients have not had any prior ultrasound, we may be surprised by finding a multiple pregnancy even in the third trimester. Women may come with the complaint of decreased fetal movements. They may be vaginal bleeding. There may be a suspicion of leaking. Or on regular clinical examination, one may feel that the symphytofundal height is less or more than the gestation on physical examination. The details of the equipment one can look up in the from the guideline. What I would want to highlight is that we all need the curvilinear and more importantly the linear probe and the transvaginal. The in obstetrics we cannot do without a transvaginal probe. So how to maintain it, the clinic protocols, they're all given in the guideline, and one can go through this. And the most important is the capacity to print and store images, because this is a medical legal document. We must ensure that we have a separate server, or we have a hard drive where we are regularly storing our images. Now, as I said, one of the key components of asking for a third trimester ultrasound is the assessment of the fetal size. So we do an ultrasound assessment of estimated fetal weight by measuring the head circumference, abdominal circumference, and fever length. The correct technique is described in this ISOA guideline, which is again, it's a document which is freely available, where to place your caliper. The images must always be magnified. We must obtain the measurements in a particular plane. In the abdominal circumference, one must. So all this is given in this guideline, which I would again encourage, because estimated fetal weight, an error of 10 to 15% is acceptable. However, it does play an important role in deciding whom to see someone next. Do I need another scan? So the correct technique is very important. And one of the most important things when we are assessing the fetal size is to establish correct dating. Because the short of dates, one should always go through all the previous papers that the patient is carrying. That you may find a small little CRL, one black page somewhere, and that might help us in establishing the gestation age. So, and once we have done this, the measurements should be plotted in a chart. And I'll just, this is a chart which is there in all the machines. All the latest machines have, if you put the same name, date of birth, the machines also, you open the examination when the patient comes the next time, so you will also get serial growth. And all the machines have these charts nowadays. The most commonly used chart is the Hadlock chart. Now, what do I do? I've done the biometric. I know that this baby is not growing well, or is this baby growing well? The Society of the Americans and the RCOG guidelines and the ISWA guidelines slightly differ here. The American Society of Maternal Fetal Medicine defines fetal growth restriction as a simple biometric measurement that any estimated fetal weight or abdominal circumference below the 10th centile is labeled as growth restricted. However, there's a problem with using this 10th centile, because if we label all the babies who are less than 10th centile, we will be labeling heavy but small babies, the constitutional small babies, as having a pathology. And we will miss out those who estimated fetal weight is more than 10, potential where the major morbidity lies. And there are several papers where we have found that 70% of terms still are not SGAs. So we must find a better way. So, and the simple parametric measurement also does not account for estimate the interval growth. So if you look at this chart where the fetus, the bottom line, you can see although the growth is on the 5th centile, the fetus is continuously growing. We've seen this fetus 4 weekly, and it remains on the 5th centile, but it is continuously growing. Whereas compare it with this fetus, where at 32 weeks, the growth was on the 70th centile. Whereas when we saw her at around 39 weeks to decide whether she needs induction or whether we should intervene, the growth, it is still on the 25th centile, but it has fallen from 75th to 25th centile. And that should alert us that here we are dealing with a baby who is not meeting its growth potential. So an assessment of the growth in the 3rd trimester by the correct technique, using the which you use serial measurements. Dynamic process, and its assessment requires multiple observations of fetal size over time. And this problem, are all small babies small? Are all
Dr.
appropriately
Chanchal,
growing
your
babies?
voice is
Yes.
going away at times, so you need to, move less
Okay,
and come closer to the microphone, please.
Is in the basement, ma'am. Is it better now?
Yes, ma'am. Yes.
For this reason, there should be no concept of just a growth scan in the third trimester. All growths in the third trimester must be accompanied with fetal Dopplers. And the Dopplers are the umbilical artery Doppler. You choose a free loop of the umbilical cord, straighten the cord so that your angle of measurement when you're putting your pulse wave Doppler is as close to 0 degree as possible. If that angulation is more than 30 degree, readjust, find another loop. Smaller to the color box, the color should not bleed all over the place. We must put it on the area of interest. So free loop, a gate of 2, and a angle as close to 0 degree as possible. There are underrated literature on measuring it in both arteries. Many times we do find that there is a difference. It does not make any clinical, I don't think it makes any difference in the clinical decision making. It might be a good practice to measure both and then take an average. Similarly, in the MCA, find the correct plane. The MCA is very, very sensitive to pressure. Many times I get referrals for an absent end diastolic flow in MCA. And if you don't apply enough pressure, you will see that the absent end diastolic flow has suddenly disappeared. So the MCA should be measured in the correct plane. Again, a gate of 2, angle of insulation as close to 0 as possible. And these are also to be plotted on charts. There is no growth scan without Dopplers. Dopplers are an integral part. And this is highlighted by the current definition of fetal growth restriction that we are using, which was given by ISWAG in the 2020. Actually, the paper was published in 2016. And in the definition of growth restriction, we have incorporated these findings. One, I want to emphasize, we do not use the SD ratio any longer. We must use the cerebroplacental ratios, because the rationale for using the ratios is because it is more sensitive. It has been found it can identify subtle changes in placental and cerebral blood flow perfusion that may not be appreciated by the evaluation of a single parameter. And again, CPR is useful in screening, but may not help you in guiding the time delivery, especially iatrogenic preterm delivery. So a low CPR is not an indication for advising iatrogenic preterm delivery. Just to highlight what we've just spoken about is, we often get reports that there is a 28-year-old primary gravida, low-risk pregnancy. She's been referred with suspected growth restriction at 32 weeks. She comes to me for a growth scan. I can see that the BPD is 32 weeks, but the AC is only 29 weeks. And she is sure of dates, and she has an early scan also. However, this information is absolutely insufficient to manage or diagnose anything. And then we put these on the charts. These charts are available freely on the perinatology.com for Asian population. You can put this, it is available on the Barcelona group, where we can put in these measurements, and you can see that the overall estimated fetal weight is within the normal range, and the Dopplers are perfect. The amniotic fluid is normal. So we use growth charts. They're all within the normal range. So AFI Dopplers were normal, and this patient went on to deliver at 39 weeks with an APGAR of 8-9. This is the correct way to do and to manage a third trimester ultrasound. One can argue, we always hear that we belong to a country which is diametrically opposite. Here we may say that no, we must do a scan at 32 weeks, and then we must follow it up with a late growth scan at 36 weeks, because we will miss the late IUGRs. However, we must account for the fact that there is disparity in access to healthcare, and there is disparity in resource allocation. So how do I choose? And even this ISWAG guidelines begins by saying that the routine application of a third trimester ultrasound has still not been proven to improve morbidity, perinatal morbidity, and mortality. I do think that this will change as more and more people are adopting a third trimester ultrasound in their routine practice, but we'll see. So if I have to do only one scan, how do I decide that when should I do it and in whom to do it? So in the second trimester, one can list the maternal characteristics which puts a woman at high risk for fetal growth restriction. One can measure and request the radiologist, because anomaly scan still is being taken up more than a routine. That is, nobody questions that you should not do a second trimester scan. One can and measure the uterine artery PI. So if we do this contingent screening, we realize that only about 50% would actually need a third trimester scan. And let's not forget the serial symphysis monitoring and plotting them on the chart. So we have to know one size will always fit all. We must try and improve our detection of women who are at risk. And again, if I'm giving one option that you will get to do only one growth scan, I think the early onset growth restrictions, because they will always be associated with in 70% of cases, there will be maternal high blood pressure. It is the late FGRs that we tend to miss. So if I get a chance to do only one ultrasound in the third trimester, I would rather do it at 36 weeks than at 32 weeks, so as not to miss out on the late FGRs. We come to the assessment of amniotic fluid volume. When I had come back from my fellowship to Delhi, I realized that the place I was working, everybody's AFI was nearing the 5th centile, 10th centile. So we made a nomogram for our healthy population. And we realized we were using a wrong chart. Our measurements were matching most closely to the Mangan's chart. And thereafter we shifted and we never had to call another patient. Very few patients were being called back for suspected oligohydramnios. So do see which charts you are using. Oligohydramnios, unless there is a history of leaking, there is a history of fever with rash associated with fetal infection, the kidneys are working properly. I think oligohydramnios, rarely do we need iatrogenic delivery, especially preterm delivery, for isolated oligohydramnios. And here, the deepest vertical pool of more than 2, which is part of the modified Manning score that we use, that is the most useful in deciding whether further follow-ups are needed or not. We must correlate, we must never take decisions on the basis of only a single parameter. We must correlate it with estimated fetal weight, Dopplers, biophysical profile, patient's perception of fetal movements. Now, polyhydramnios, again, there is a lot of disparity in when people in reporting polyhydramnios. So I think the mild polyhydramnios, the 25 to 28, 30 group, they're mostly idiopathic. One must make sure that the woman does not have diabetes. And if she has diabetes, it should be controlled. It is when your A5 starts crossing 30 that one must start suspecting that there may be a problem in the baby's swallowing, or the baby may be urinating more. Twin transfusion syndrome and inherently polyhydramnios will be associated with the risk of preterm delivery, and therapeutic drainage may be required. So I'll just share a very interesting case with you. This lady was booked with me from viability. So it was a low-risk primary gravida. The anomaly scan at 20 weeks showed mild poly. So we did an OGTT and we called her back at 4 weeks later. And subsequent scans just showed progressive polyhydramnios. It went from 25 to 30 to 35. And if you look at the fetal bladder, can you see how distended this is? Now, at this time, you can see the cervical length was barely 5 millimeter. So at 26 weeks, 27 weeks, and she was in a lot of discomfort, we offered an amnio drainage, drained out around 3.5 liters in one setting. And you can see that there is elongation in the cervical length as soon as that fluid was drained. However, the problem was that it just deformed. We sent it for whole exome sequencing. However, the whole exome sequencing, with a suspicion of Bartter, it does take about 4 weeks to come. The baby was proven to have Bartter, which is a good prognosis if it is known antenatally. Most of the time, an antenatal diagnosis in the third trimester just helps us in planning better perinatal and obstetric management in terms of NICU care and in terms of place of delivery. And I did 4 amnio drainage. She required one every week. At 33 weeks, she was planned for another one, but she leaked just before we were planning to do. So this baby is currently well. He is in regular follow, but he is currently doing well. And the third most important, do let me know if I have time, Dr. Asha. This is the last part of the lecture. So, placenta localization. One point which I must emphasize, in fact, there are 2 points I want to emphasize here, only 2. You must do a transvaginal scan for diagnosing or excluding a low-lying placenta or a placenta previa. If the leading placental edge is 20 millimeter or more from the internal cervical os, vaginal birth is considered a safe option. However, you cannot do this on the transabdominal scan. So TVS is a must. We must put a color Doppler at the internal os to make sure we don't miss vasa previa, because bleeding in that case will be fatal for the fetus. And the new kid on the block, which has become now old, we are seeing in the morbid adherent placenta very, very frequently. And the only thing that makes a difference here is antenatal diagnosis. So one must have a strong suspicion, previous multiple DNCs, previous cesarean, previous myomectomy, and a placenta which is adherent. The antenatal is very, very accurate, more than 95%. You will find that there is disruption of the interface between the bladder and the uterine wall. And there is a lot of increased placental vascularity. If you see in the panel above, there is a well-defined myometrium here. And if you compare it with this picture lower down, which is a transvaginal picture, you find these lacunae. There is a complete loss of the retroplacental hypoechoic zone. So we must put Dopplers, we must do a transvaginal scan. The presence of placental lacunae, increased vascularity, should prompt a suspicion of MRI, presence of bulges into the bladder. And this is the specimen. This woman required a hysterectomy. You can see that the incision has been given so that we don't go into the placenta, and you can see this blood, this bulge. And it was histopathological proven. We must not try to make an effort to diagnose whether it is accreta, increta, percreta, because these are histopathological diagnoses. So to conclude, an ideal world, I would want to offer a 3rd trimester ultrasound at 32 weeks and then at 36 weeks. No growth is complete without Dopplers. And every growth scan must be an opportunity to pick up abnormalities which may arise in the 3rd trimester. And we are not infallible. We may miss it in the 2nd trimester. Serial growth, use charts. Transvaginal scan is a must for placental localization and diagnosis of adherent placenta and vasa previa. Thank you very much.
Thank you, Dr. Chanchal, for that concise and crisp talk. I now request Dr. Ansi Jacob to give a few concluding remarks regarding the same.
Thank you, Dr. Chanchal. She has given a elaborate discussion about the whole our concerns regarding when it should be done, what all things we need to see during a 3rd trimester scan, all the things, all our doubts. I think it has been now completely cleared, and especially with her reference to the use of charts whenever you go for diagnosis of oligomneus. Those points are very well taken. So I think it was a very wonderful session. Thanks to Dr. Chanchal.
Thank you, Dr. Ansi. Dr. Chanchal, you were very much on time. So no worries. And now, it's important for us to understand that a 3rd trimester is needed and it should be done well. Just getting the 4 parameters and putting an estimated fetal weight doesn't work. So that point is very, very important that you emphasize today. And to all my colleagues, gynecologists, when you refer your patients for a 3rd trimester scan, just see that everything is done. That is the purpose of this talk, that we should know what should be there in the report. So with that, over to you, Sujaya, to start the 2nd session.
So moving towards the 2nd session, it's on late detectable anomalies. First, I would like to introduce the chairpersons for this session. We have with us Dr. Prasad Halkarnikar sir. He's the president, Kolhapur OB-GYN Society. He has his private practice in Kolhapur since 1990, and his areas of interest are infertility and vaginal surgeries. Welcome, sir. Next, we have Dr. Annama M.G. Mohan. Ma'am is the president of Kollam OB-GYN Society. She's a senior consultant and HOD of OB-GYN NS Hospital, Kollam. We have Dr. Ritika Mathur with us. She's the president of Kota OB-GYN Society. I request Chairperson Dr. Prasad Halkarnikar sir to please introduce the speaker, Dr. Chandralula sir. Dr. Prasad, would you please do the honors, sir?
Yes. Yes. Dr. Chandralula is considered sonologist and fetal medicine specialist. He is ex-president of IFUMB, ex-councillor of AFSUB, ex-editor IFUMB, ex-ISUOG ambassador for India, and ex-dean of IFUMB. I request Dr. Lula to carry on the lecture.
Right. Thank you for the kind introduction, and thank Dr. Asha Jain and SearchLite team for this wonderful theme-based conference. I think it's really an eye-opener for us also. Going through third trimester anomalies, we have a whole spectrum of anomalies. Can you see my screen, please?
Yes, sir.
Yes.
Okay, so there's a whole spectrum of anomalies. I don't think I'll be able to cover everything, but whatever I can, and then you please let me know the time schedules. So whenever we talk of anomalies in the third trimester, these could be late insults, which happen late in the second or third trimester. There could be anomalies in evolution, which have a natural history, something like a cardiac valvular stenosis, which may ultimately present in the third trimester or be picked up in the third trimester, like a small VSD, which is not apparent in the second trimester, but because of increasing circulatory pressures, it is apparent in the third trimester. There could be missed abnormalities in the first trimester, which may accidentally come up on the third trimester scans, and that, of course, is unfortunate. So diagnostic accuracy of fetal ultrasound depends on the results are higher when the exam is performed on high-risk individuals, when it is performed in specialized centers, and when major malformations are considered. Of course, in low-risk centers, because the focus is less, you may miss some. Now, this is a very important paper of what can be picked up as early as even the first trimester. You can see that major abnormalities of CNS, skeletal system, cardiac are all today picked up in the first trimester. There are some that are occasionally picked up: posterior cranial fossa abnormalities, cleft lip, cardiac abnormalities, congenital diaphragmatic hernia, and some that will never be picked up in the first or second trimester, like bowel atrasias, the lung malformations, ventriculomegaly may present in the late third trimester. And therefore, this is the big group of abnormalities that we see in the third trimester. Anomalies that are detected before 24 weeks, high detection rate of central nervous system, urinary tract, skeletal abnormalities, and low detection rate of GI tract and cardiovascular. Cardiovascular essentially because the heart is small, and as the heart grows, you can pick up these abnormalities better later. And gastrointestinal are because the fetus is not aspirating amniotic fluid beyond 13, 14 weeks, and it used many of these abnormalities will present after 20 weeks, especially with Liker disturbances. Now, if you see this very recent study of almost 140,000 women published in the BGAOG, almost 3.7 per thousand women with fetal anomalies were diagnosed in the third trimester. And I think this is a very, very important figure to keep on your table for some patient who really questions you as to why this was not picked up in the second trimester. So the common being urogenital, CNS, and cardiac, and you can see the percentages. The late onset anomalies are usually CNS and can be of every system involved. So we'll just quickly go through some abnormalities. There can be evolving abnormalities, late detection, and of course, delayed diagnosis in the third trimester. Usually, we may see liker disturbances, and this may point us to the fact. So here you have a fetus with severe oligo, and we know that there's a distended bladder, and that suddenly now there is a massive hydronephrosis. Or there could be a massive polyhydramnios, which guides us to the fact that we could be dealing with a GI abnormality like a bowel obstruction or a TE fistula, which has not been seen. When we are looking at CNS abnormalities, these could be acquired abnormalities secondary to stroke, hemorrhage, and infection, or developmental abnormalities which may present late, especially the cortical disorders in the late third trimester. And of course, when we are doing a third trimester scan, it is mandatory that we look at almost all the organs. And I think, honestly speaking, we have always been doing this since last 30 years. I can tell you that when we were doing third trimester scans, we used to always look at the anatomy. Only now, because the ISWAC guidelines have been published, there is renewed focus. I think most fetal medicine specialists like Dr. Chanchal and others will bear the fact that this is not something new. We have always been looking for it, and it is just that this has come to light now, and it has been made more conceptualized with this new paper and new guidelines. Ventriculomegaly is one of the most important things that we do see later in pregnancy, and this may appear very mild in the second trimester and may progress to severe ventriculomegaly in the third trimester. And of course, we pick up aneuploidy in the first and second trimester, so that's not really what we are looking for, but we are looking for clastic lesions like infections, vascular lesions, malformations, and tumoral lesions which may be picked up. You may pick up very mild hemorrhage in the third trimester. As you can see, there could be mild vascular insufficiency, and you may pick up grade 1 hemorrhage, or it may progress and you may see massive sudden. This is really a third trimester fetus who came to us with absolutely normal previous scans with this kind of presentation on a routine third trimester scan. So you see generalized ventriculomegaly with obvious hemorrhage seen in the periventricular area and the intracranial area. This was a twin pregnancy with single fetal device, and we were following up the second fetus, and you can see at 31 weeks we had intracranial hemorrhage almost 6 weeks after demise of the first fetus in the second fetus. This was an interesting case of a IUGR baby who came with absent diastolic flow, and we were going to deliver almost the next day. Everything was planned. You can see that the middle cerebral artery was normal, and lo and behold, the next day when we just scanned the fetus because of loss of sudden movements, you could see massive cerebellar hemorrhage here. You can see the whole cerebellum is washed out and white, and the baby was really in bad shape at the time of delivery. Now, this is not an uncommon presentation in the late third trimester. This is a typical superior sagittal sinus thrombosis. You can see that's the clot. That's the massive hemorrhage here in the region of the dura, and there is elevation of the straight and superior sagittal sinus. So this is a very common manifestation in the third trimester. Now, this is what we always dread. You have a history of infection, or you may have no history of infection, and lo and behold, third trimester, you see ventriculomegaly and extensive intracranial calcification, indicating that the fetus has suffered a massive infection, which has presented late. And also another case of toxoplasmosis here. You see multiple nodules in the fetal brain and with ventriculomegaly. So these are acquired lesions, and they can present in the third trimester. Here, this fetus actually came to us with a Blake pouch cyst, but on close inspection, we could see that there was no corpus callosum. So obviously somebody had missed and focused more on the posterior cranial fossa. And this is an important message that when we have one abnormality, please look for the other abnormality. Now, cortical disorders will present late, especially in infection situations. I'm not going to go into details, but this is a kind of smooth appearance of the cortex suggesting lysencephaly, and this is an irregular appearance of the periventricular zone, and as you can see here, suggesting periventricular nodular heterotopia and polymicrogyria. So these are some late. Vein of Galen malformation may not present earlier if it is small, and suddenly in the third trimester you may see a massive malformation with cardiac overload. This was an interesting case who we came with this kind of picture in the third trimester, and we thought this is a classic destructive lesion, but we could see that the vessels are displaced from the midline, and this was actually the Sylvian fissure which was displaced, and we had to resort to doing an MRI to really understand. So MRI is a useful tool even in the third trimester, and this was a suprasellar craniopharyngioma which was displacing the brain upwards. The brain otherwise was normal, and this mass was extracerebral in location. So it's an important message being here that sometimes we need to do an MRI in the late third trimester. Sometimes abnormalities correct themselves in the third trimester also. So although we pick up abnormalities, this was a fetus with a Blake pouch cyst presenting at 22 weeks. Almost everybody called it a Dandy Walker malformation on MRI. You can see the vermis is well formed. It is rotated and we thought this was a Blake pouch cyst. We followed up at 24 weeks, similar appearance. 28 weeks, there was a little less rotation, but at 32 weeks, there was final closure of the Blake pouch and the vermis had become midline. So these are sometimes the reverse situation where actually things correct themselves due to the natural history, and this fetus would have unnecessarily been terminated. So we need to be careful about knowing the natural history. Valvular abnormalities and cardiac abnormalities may start in the second trimester and then may progress to the third trimester as very poor cardiac function, and ultimately the chambers may shrink and become echogenic, as you can see the typical progression of the hypoplastic left heart syndrome. And this is another fetus with aortic atresia and mitral atresia with almost near complete hypoplasia of the left ventricle. This is a very mild aortic stenosis which presented late with post-stenotic dilatation, and otherwise initially the four-chamber view of the heart was completely normal, and this is the picture that presented in the third trimester. You can see turbulence. There was good four chambers, mild cardiomegaly, but otherwise good cardiac function and only aortic. So the prognosis here would be good, and this can be corrected later on in life. There are some markers that we may see in the second trimester, which may be harbingers of abnormalities that may not be seen till later third trimester, or sometimes even in the neonatal period. For example, just to give one example, this is the PLSVC, which drains into a dilated coronary sinus, and this may be a harbinger for a coarctation of the aorta. So you need to look for it in the third trimester. Sometimes even in the neonatal period, this may present, and this is another fetus with the same. You can see the small aorta presenting as coarctation. Cardiac tumors may present both in the second and third trimester. They have a good prognosis, usually if there is no intracranial involvement, and there are some treatments also available. So this is a typical tuberous sclerosis rhabdomyoma, which we are seeing in the fetal heart. We may see volume overload due to some vascular shunts which are tiny. This is, of course, a vein of Galen malformation. This is a ductus venous agenesis. But this was a small pulmonary AV malformation which was causing massive cardiomegaly and ultimately led to hydrops. Ductal constriction is a typical feature which we may see in the third trimester due to excessive caffeine intake or NSAIDs, and you may actually see massive cardiomegaly with dilatation of the right side of the heart, turbulence in the ductus, and with very poor flow going across into the ductus. So this is again a third trimester feature which is not too uncommon. Dr. Asha Jain just said that we have seen in the past many congenital diaphragmatic hernias presenting, but we must focus on some clues which may be seen on the second trimester. You can see here color Doppler, the mesenteric artery is moving upwards. Here the umbilical vein is curved in its fashion, which may be a clue that you may be seeing a a congenital diaphragmatic hernia, which may present later. So some clues may be available, but many times you may actually see a third trimester because as the fetus starts swallowing, the stomach distends, and this pushes the stomach up into the heart with distension. This was a very interesting case we saw recently, 33 weeks. You can see that the stomach is trying to undergo a kind of volvulus here. Intermittently, it was rotating along its own axis. And also, it was pushing its way up with probably a small defect here. You can see behind the heart going there. So two kind of problems. It was rotated and pushing upwards at 33 weeks. Fortunately, we could see it. We could deliver it. There was a small rent in the diaphragm, and through which, with every respiratory movement, the stomach was going up like a hiatal hernia, which is very rare in the fetal period. This was a fetus which had an intact diaphragm, but placed very high, and you can see that this was an eventration of the diaphragm, and that is seen almost behind the heart, although even the mesenteric vessels were going up, you can see in a reverse direction. And post-operatively, there were very few muscular leaflets in that diaphragm, almost like a diaphragmatic hernia, but because of the intact diaphragm, this was presenting as an eventration in the late third trimester. This is a very, very small form of diaphragmatic hernia with only a single bowel loop going up. You can see on the sagittal view. The stomach was in the abdomen. On the axial view, you could just see a small lucency almost appearing like a pericardial effusion. But on the sagittal view, you can see that there is a very small diaphragmatic hernia. Chest masses usually present in the second trimester, but sometimes they regress. Most of the times they will regress. Very rarely if it's a hybrid lesion, and it may progress to hydrops, and this may be seen in the third trimester. Of course, now we have laser with which we can treat these conditions and ablate these conditions. So that was a microcystic. This is a macrocystic CCAM, and most of these will regress, but if they are so large, then they may progress in the third trimester to hydrops. Here in which we can then put in a shunt here, as you can see here, and do an intervention to reduce the burden and reduce the occurrence of hydrops. This was a 31-week fetus who presented with sudden onset bilateral pleural effusion. And normally we would aspirate this if it is a primary effusion, because it was bilateral and causing early hydrops. And you can see that's an aspiration being done at the first attempt. And then, of course, we will put in a shunt if it recurs. But fortunately for us, this never recurred. What we did find interestingly was the lipid profile of this mother was extremely abnormal. Her lipids were almost to the tune of 400, etc. On cutting down her lipid in her diet, we saw that this pleural effusion never recurred. So sometimes we have to be ingenious in our methods of treatment, and post-aspiration, this fetus did well. The other group of disorders, of course, we see very often is hydronephrosis suddenly ballooning out. And if it is more than 15 millimeters, we know we are headed for trouble. And this could be due to a posterior urethral valve, or sometimes even just isolated PUJ obstruction. And here you can see there's a fetal urinoma that is developed due to a posterior urethral valve. This was recently we had this 28-week fetus, although presented at 20 weeks with a posterior urethral valve. We did a shunt, but up to about 23, 24 weeks, she did well. And then the baby pulled out the shunt. So around 24, 25 weeks, we then had to puncture the bladder, put in a fetoscope, and put in a laser fiber. That's the puncture here. You can see here into the bladder, into the posterior urethra. That's the fetoscope. And that's the valve that we could see on the fetoscope, and we could fulgurate it with laser. And this fetus did well and we delivered at 34 weeks. You can see this is the pre-laser bladder. This is the post-laser bladder. So these are, of course, situations where we are called upon to act. Now, this was a very unfortunate case. 28 weeks presented to us with polyhydramnios, fetal ascites, a dysplastic unilateral kidney. And you can see that the bladder was also distended. The colon was also distended. That's the perianal muscular complex that you can see here. And we couldn't see the genitals here. And this was polyhydram. So obviously we were dealing with a cloacal defect. And here at 32 weeks, we could also see a double bubble that was manifesting here. So sometimes abnormalities evolve into the third trimester. You may see one abnormality earlier and then it evolves into the, and this was actually the picture post-birth. You can see the perianal muscular complex that we considered is actually only a single opening. There is no genitals which we could not see. And of course, this was also the duodenal atresia, and this was the posterior cloacal malformation, which, and these are the pictures of CT scan with the hydrometrocolpus, what we were seeing. So sometimes these are progressive lesions. But one thing I must tell you was that despite telling the patient that we must terminate this pregnancy even as late as 28 weeks, they decided not to terminate. They said, come what may, with any number of abnormalities, we want this baby. And this baby has had 3 surgeries till now and is doing well. So sometimes, despite our interventions, the patients decide otherwise. Posterior urethral valves will not always be doomed. This is 28 weeks. You can see severe posterior urethral valves with normal Leica. So here we really don't need to do anything. An ex utero correction is enough. Bartter syndrome also, Chanchal just spoke, so I will not talk much about it. But again, this is one of the most disturbing situations because you have to repeatedly tap. You can use indomethacin, and ultimately then they leak. And then this baby was delivered at around 30 weeks and is actually doing well. So we were not really hopeful for this baby, but they do well. Polycystic kidneys may manifest late in the third trimester, although many of them will present in the second trimester. GI tract malformations is really what we see very oftenly in the third trimester. This is, of course, gastroschisis with bowel changes due to prolonged exposure in the amniotic fluid. So although picked up early, good prognosis, the chemical peritonitis may cause bowel wall thickness, and this may lead to problems. If you don't see the fetal stomach, by 20 weeks, we know we are facing a problem. This is, of course, a teratoma, but this was picked up early. But this is something was picked up late. Here we see a large mass lesion which is calcified, which presented with an absent stomach in the third trimester. And this turned out to be a teratoma, which was just not seen in the second trimester. So this is probably something which grew during the period of time. Of course, esophageal atresia and TE fistulas, sometimes you may see an esophageal pouch in 40% of cases, but many times you will just see an absent stomach. This was an interesting case of the late second to early third trimester of a polyhydramnios, but what we were seeing was a cystic swelling in the pharynx, compressing the pharynx. You can see that here, and that is well seen here in the neck. And that again here you see that is a cystic swelling, and this turned out to be, this is the postnatal picture, of course, looks more dramatic. This was a vallicular cyst, which if not detected antenatally can cause severe respiratory discomfort. And fortunately, we had known and we could do a correction. This was laryngoscopy done at birth, and just by puncturing this cyst, the fetus, the neonate survived. Otherwise, would have landed up with severe respiratory abnormalities. You may see GI abnormalities in tandem. So this is a fetus with both duodenal atresia and esophageal atresia. So when you find one abnormality, look for the other. This is, of course, a band of lard which presented with a volvulus later in the third trimester. Bowel obstructions, as I told you earlier, as the fetus swallows, you start seeing dilatation and may present with a spectrum of pictures like fetal ascites, meconium peritonitis, and calcified pseudocysts, which may present late. Colonic obstructions may present late because they don't usually present with bowel polyhydramnios. So usually this is a late presentation. And of course, if the fetus is moving too much and the mother is complaining of excessive movements, please look for a bowel volvulus, and this is what you may see in the fetus. This is an interesting abnormality. Unfortunately, this clip is not working, but this was a dramatic appearance. This ultrasound showed multiple dilated bowel loops, and this is actually a chloride diarrhea. which results in uniform dilatation. You can see the MR. There are multiple dilated bowel loops and should not be mistaken for bowel obstruction. This is a pediatrician's nightmare if they don't know about it. So the moment they know, they are well prepared and can be tackled. This is another fetus, very commonly seen late presentation is a ovarian torsion. You will see a complex mass close to the bladder with echoes, and sometimes the fetus is having excessive movement. Skeletal abnormalities, another nightmare, especially achondroplasia. You can see typical appearances of late presentation, the trident hand, the short femur, and of course the angle that is the metaphyseal diaphyseal angle, which is widened, which can come to our rescue. But essentially, we see that the long bone appears shorter after the second trimester, and this can be a kind of nightmare. You see some very rare abnormalities, and you have to look for hidden clues. So if you have a small foot, this is due to fixed flexion contractures. This can be an Harlequin fetus. This was a twin fetus with one normal fetus here. This was another fetus where we were seeing hyper-echogenic densities in the brain, fractures here, and this was a skeletal dysplasia as osteopetrosis. Sometimes the abnormalities may be very minor. Here we have a fetus who had this inward the valgus deformity of the knee and good movements, polyhydramnios, but this was a congenital dislocation of the knee which was presenting in the third trimester. Hydrops is also one of the pathologies, especially RH, but chorioangiomas can present in the third trimester, and here we can do a cyanoacrylate injection. This can cause ablation of the chorioangiomas, and there are some rare hydropic conditions, like here, this is a pseudo-torch situation where fetus she had a previous history of hydrops, but only the diagnosis was only evident on every other investigation was negative, the MCA, Doppler, etc. But the clinical exome showed us the presence of a cardiac syndrome, and this also can mimic a torch toxoplasmosis because they have intracranial calcification. A cardiac abnormalities, again, this is not working, this clip, but this was an atrial flutter. You can see here very rapid heart rate leading to hydrops, and this may this may present initially as a premature extrasystole, and on follow-up, suddenly it may have an escape predim with a SVT. Now, last 2 or 3 cases, this fetus just kept keeping the foot like this on the face, not moving the foot, and we were seeing the cord in close position with the foot, and you can see that the fetus had tied a knot of the cord around the fetal limb and constricted the limb, causing limb ischemia and gangrene. And this was, I think, one of the, I haven't seen a parallel manifestation like this. It was almost as if the fetus was had wrapped the leg and presented with this kind of situation. So amniotic band ruptures here, amniotic band syndrome is another feature where you may see amputation of the digits, and this may present, you may not actually see the bands, but you may see these drop kind of echoes, and of course constrictions with swellings in the foot, as you can see here typically. The last case I would like to present is that because this is one of the most the second, I think, most common cause of a stillbirth is vasa previa. This can only be picked up in the third trimester if you haven't looked for it in the second trimester. So important message is that when you do an ultrasound, please look for the cord insertion and where the cord vessels are flowing, specifically if you have a low insertion of the low placental position. I think Chanchal has already spoken about morbidly adherent placenta, so I will not talk about it. So in conclusion, I think prenatal diagnosis and looking for abnormalities is important in the third trimester, because sometimes you may pick up rather these unusual abnormalities, a whole list of them I have shown you, and the eventual birth of these fetuses should happen in specialized centers, and the timing and type of delivery can then be adjusted so that you have the appropriate assistance. Patients are prepared. Sometimes we have even done a late amniocentesis and a late microarray to prove situations like acardie and other others which otherwise would be considered as infection, you then can plan your neonatal follow-up if specifically if the abnormality is missed, which this would may become very difficult, like cases like chloride, diarrhea, etc. And of course, we are now fortunate that our government is, unlike the American government, is permitting late abortions, so our country is moving forward, and countries like America, which have banned abortions, are moving in a retrograde direction. So I think there's a definite role for third trimester ultrasound. But only thing I must tell is that this is not something new. We have been doing it all along. And I think people like Chanchal, myself, many other people have always been looking thoroughly of the fetus and not just looking at measurements and cardiac activity. So I think this activity of looking at the anatomy should continue. We have new and new abnormalities, evolving abnormalities, which we will always pick up for the first time in the third trimester. Thank you very much. And if there are any questions for both of us, we would love to answer it.
Thank you so much, sir. Thank you.
We request Dr. Prasad to please give a few concluding remarks on this talk, sir.
Yeah, just a second. All our panelists are here. I would request anyone who has any kind of question can, ask both the speakers. If you have any question anyone wants to ask before we proceed with the panel. If no questions, then Dr. Prasad, sir, would you please conclude?
Sir, it was a very elaborate lecture, and so many conditions you showed which we were unaware of, and we could diagnose and treat it in antenatal period. So it is a very eye-opener session. I think we are very thankful for this elaborate lecture and the information that is given in this lecture. Thank you, sir.
Thank you. Thank you.
Dr. Priya, would you like to say something?
Yeah, ma'am. Good evening, Asha ma'am, and good evening, respected speakers, Chatar sir and Dr. Chanchal ma'am. The lectures have been really elaborate, and what I was listening to, the preciseness, like the way we need to interpret the ultrasound when it comes to even a normal pregnancy or be it a high-risk pregnancy. I would like to address just one question, ma'am, if you permit me, to both of our speakers, like being an obstetrician as well. We are getting day-to-day sonographies even from outside, and many of the times the findings are really missing in detail. And what kind of medico-legal significance does it hold, or we can emphasize the patient to get it screened again by a fetal medicine expert? Is it really mandatory in today's scenario, sir? Because the way you have asked enlighten us about the detailed third trimester anomalies, maybe the majority, few of the patient, I had one case where multiple anomalies were encountered at 32 weeks of gestation, and by that time the MTP law doesn't permit any kind of termination. It was very difficult for us to justify and get a screen again after the thing. So how do you counsel, and what on our part as an obstetrician we should focus upon?
So if I may be permitted to answer this question, I think there are two types of ultrasound. One is a basic ultrasound, which is a non-anomaly scan, which is a dating scan or a growth scan.
Yes, sir.
And the other, whenever you call anything an anomaly scan, it is inherently presumed that it is being done by an expert. So it's not important who's doing it. If you're calling it an anomaly scan, there is no business for you to miss anything. You have to do a proper scan which can follow the guidelines, established guidelines, or you can use any of your own methods. But what's important is that major malformations cannot be missed, because what the court of law sees is that can this be picked up by anybody of reasonable equal standards, and if so, then he has no business to miss it. So I think when you say that you're doing an anomaly scan, you're in itself telling the patient that this is an expert scan. It may be done with a fetal medicine expert, by radiologists, by sonologists. There are not so many fetal medicine specialists to serve the whole country. So
Yes,
we
sir.
have to rely on experts who are not dedicated fetal medicine specialists. They may be radiologists, they may be sonologists, they may be people who are doing only fetal ultrasound. So the onus is on them. If they are doing an anomaly scan, they better have to deliver the goods.
Right, sir. Thank you so much, sir.
Dr. Asha, can I ask one question to Dr. Chandralula?
Yes, ma'am.
Dr. Chandralula, we always ask for the second trimester at 20 weeks malformation scan and 2D echo between 22 to 24 weeks. Now, in a third trimester, when we do a sonography, we usually ask for the interval growth and the liquor and the placental localization. So, would you like to suggest that in third trimester also we should do one malformation scan?
I mean, yeah, you may just write an additional word in the same scan, that anatomical survey. So you can add growth, anatomy survey, and placental localization, and that will cover everything. So we essentially will look for everything and will cover everything in that scan.
Okay. So
It's a good
the
idea.
message.
It's a good idea to write anatomical survey.
Okay. So the message is very clear that in third trimester also you must have a anatomical survey. Thank you, Dr. Chandra.
Thank you, ma'am.
There's one question from Dr. Gayatri Singh on YouTube, sir. So she is asking that when can umbilical hernia be diagnosed?
Umbilical hernia is basically protrusion into the umbilical cord. It can be physiological, it can be permanent. So it's unlike an omphalocele, which is it's a large bulge. This is a diffuse bulge, and if it doesn't regress, then it may just remain like a projection there, and this is called as an umbilical hernia. So I mean, it's just a loose term for any other projection, any other kind of hernia which is seen, which is not an omphalocele, which is not as large as an omphalocele.
So means her question was, when can it be detected?
Usually, see, physiologically it is seen before 11 weeks, and after 11 weeks we call anything a hernia or an omphalocele.
Thank you, sir. Thank you.
So
I think thank you so much, Chanchal ma'am, Chandar sir. We would be really grateful if you can stay along for expert comments in the panel. And also to my special guests, Dr. Sita, Madhuri ma'am, even Leela ma'am, everyone was here. Now, with due permission, we will start the panel. So we are going to start the panel now. And this is basically a revision and also an interpretation from the gynecologist's point of view. That once something has come to you, what are you going to do? That is the viewpoint with which this panel has been made. That's me, I've been introduced. I request all of you to please nominate me for Food, Drug and Medical Surgical Equipment Committee from your societies. Nomination letter will reach you shortly. And my expert today is Dr. Purvi Agrawal. She's an executive member of Society of Fetal Medicine, Raipur. The panelists are Dr. Priyanka Memani. She is the Secretary of Karnal Society. Dr. M. Malini, past Secretary of Karur Society. Dr. Meenakshi Agrawal, Secretary of Kashipur Society. Dr. Lakshmi Pai, Lab Surgeon, Deepa Nursing Home, Kanhargarh. Dr. Indraneel Jadhav, Secretary, Kolhapur. Dr. Khushbu Meena, Secretary, Kota. Dr. Neha Sehra, immediate past secretary, Kota. Dr. Bharti Gahatori, fetal medicine expert at Kashipur. And Dr. Priya Gupta, immediate past president, Kota. So welcome, dear friends.
Thank you so much.
Some have logged out due to emergencies, but anyone who's present here, you are all welcome to interact. So the first principle of ultrasound or anything, medicine itself, is first do no harm. Primum nocere. So there is the ALARA principle. You have to examine the patient as much as needed, but efficiently to cause minimum harm. So let's start from the beginning, a very good place to start as the poem goes. What are the indications of ultrasound scan in the third trimester?
Ma'am, shall I?
Yeah, please proceed.
As Chanchal ma'am has really elaborated a lot about this. So the indications for third trimester ultrasound is number one, we need to have a proper detailed fetal growth assessment, because in the initial trimester already the NT scan, what we call is at aneuploidy scan, is usually done at 11-13 weeks. Then we have a level 2 scan where the detailed fetal anatomic survey has been done between 18 to 22 weeks. So when it comes to third trimester, the majority of the couples, they're more concerned about the proper growth assessment of the fetus in utero. So a detailed growth scan, then like as the sir has, we can have a revision of the anatomical survey. Whether are there any new relevant developmental defects which are highlighted in the usually in the third trimester, like the CNS abnormalities, few of the cardiac abnormalities, they're highlighted usually in the third trimester, then skeletal.
Just
these
in
all things,
short,
yeah.
just in short,
Yeah.
what are the
Then,
indications? What
then
one you said was growth.
yeah.
The second is to search for anomalies.
Anomalies. Then we see the fetal position, the Likert assessment, the placental localization, because it's almost, then we find out the cervical length, the oligo or poly. So these all, ma'am, be taken to details.
Okay.
And ideally, when it should be done, usually the recommendations are of 32 to 34, or majority, if a patient can not go through the 32-week scan, then we can have one scan at 36 weeks. That will suffice.
Dr. Neha, you've been listening very intently. So I'm asking you now, if it were your patient and Dr. Chanchal ended up that she wants one scan at 28 to 32 weeks and another at 36 weeks. Supposing you were given a choice, which date would you prefer?
Ma'am, if she's a uncomplicated pregnancy, a normal pregnancy, then definitely I'll prefer a scan at a 36 week.
Being an obstetrician, I would say that uncomplicated pregnancy is a retrospective diagnosis. It's only once the baby is in your hands and the mother is well that you can say that, yes, this was uncomplicated.
Ma'am,
Otherwise,
see, if she don't have any recognized medical disorder, if she's a singleton pregnancy, spontaneous conception, and she's doing well and level 2 scan is normal, then definitely I will opt for the growth scan at 36 week.
Okay. Now I want, Dr. Jadhav, I want your comment. If an early pregnancy scan has shown, means a mid-trimester scan has shown that the distance from the leading edge of the placenta to the internal os was 1.5 centimeters.
Then I will surely go for a scan at 28 weeks, ma'am. Mostly till 28 weeks, due to placental migration, maybe some 10% may be low lying. Again, it should be again confirmed at 32 weeks. If at 32 weeks, I am seeing that lower age of placenta is still 1.5 centimeter, may be considered as low lying placenta. Also, we have to see if it is anterior or posterior and does it actually interfere with the cesarean section. Also, like we have to see if at all, if the head is obstructing or how is the position of the fetus. Mostly due to less space at a lower segment, mostly it can be a breech presentation. So all these factors I have to check. So I think a scan should be done at 32 weeks, if at all. 28 to 32 weeks, one scan should be done to know if lower age of placenta was 1.5 centimeters from internal.
Okay, so the guideline says 32 here. So 28, yes, for ourselves, but 32, it has to be done anyways. So now, we go to the amniotic fluid volume, placental location, Dopplers, growth retardation, PROM. These are all the various indications. Now we come to the first case. This is a 22-year-old Gravida 1, para 0, singleton pregnancy with no maternal complications in pregnancy. But when she comes in, at 32 weeks, the scan shows AC and fetal weight at the 10th centile. Now, what do you want to see? How are you going to label this patient? SGA, IUGR?
Ma'am, can I answer?
Who's?
Dr. Lakshmi.
Yeah. Lakshmi, please go ahead.
Yeah. Ma'am, since she is at 32 weeks right now, she comes into the late, means the later pregnancy part. She's 8 months plus. And abdominal circumference as well as the fetal weight is at the 10th centile. So we'll have to, like, though it is more towards SGA, we also have to keep FGR in mind and go ahead.
So what actually in this, what more do you want to see?
But ma'am, report is not completed without a Doppler.
Yes, ma'am.
So we cannot take a decision for the effective fetal weight and AC only.
Yes,
ma'am. Can I add a point?
Agreed. But one more thing is that would you see her past reports?
Yeah.
Yes, ma'am.
Yes, ma'am.
See, that is important because she is now at the 10th centile. But as Dr. Chanchal showed you, that it was at the 5th, but it remained at the 5th.
So interval growth we should see for in the previous
So
scan.
you want to see the interval growth.
Yeah, ma'am.
Ma'am, in this case, basically, both the abdominal circumference and the expected fetal weight is on a lower side. That is, it is around the 10th centile. So it is more in favor of IUGR or fetal growth restriction. Yes. So when it comes to a small for gestational age patients, usually the fetal weight is affected, but not the abdominal circumference. AC is usually not affected in SGA fetuses. So we can have a 15 days revision scan or a prior scan can be compared, and the Doppler can be added upon to see for the factors which may lead to such case.
Dr. Purvi, are you there?
Yes, ma'am. Good evening, ma'am.
Good evening, dear. So now here is a controversy that in SGA, the AC is not affected.
Ma'am,
I would like your opinion on that.
So we have a clear-cut demarcation of AC and estimated fetal weight. If it is less than 3rd centile, you can definitely label it as FGR. But as per the definition, if it is still at 10th centile or below, you call it SGA. It can proceed and become FGR in a later date, but as of now, before labeling it as FGR, you need to have the Doppler parameters.
Ma'am, there is some different opinion regarding mine.
Yes, sir.
Yeah,
Please
actually, only AC should not be seen. We should see for BPD, HC, and FL also.
Sir, actually, that is how you get the estimated fetal weight, you know. When you are doing the EFW,
I know, I do
so
understand,
you have
ma'am.
already done all of that. So that is how you got the fetal weight, which is at the 10th centile.
No. If the same are having 10 centile in the previous scans and in the previous scans,
yeah, so
with
you want to compare
interval
with
growth
the previous
maintained,
scan.
If interval growth maintained with that, then we should suspect more amount of SGA rather than IUGR. But suppose that in previous report now the interval growth has a lag, and also you are seeing that only AC parameter is much more deep than the other parameters. with Dopplers which are deranged, then only we can actually differentiate into FGR, ma'am.
Sir, I think we also, as gynecologists, have an advantage. The patient comes to us, right? Now, if the patient is 4 feet 10 inches and 40 kgs,
then most likely she might be having HJ baby.
so we actually also have to look at the constitution of the mother and the Dopplers, of course. So here, the DD is FGR. How are you going to follow up this case? Right now, her Dopplers were done. They were normal. Okay, now how are you going to follow up this case?
Madam, Dr. Lakshmi here.
Yes, Lakshmi.
Ma'am, 2 weekly would be enough, I feel, if the Dopplers are normal. 32 weeks, we get her back at 34 weeks. And we do a scan. We see the growth interval. We see the Dopplers once again, and we compare the data. Of course, she should be told to look for the fetal kick count and any other complaints which come in between. If everything is normal, 2 weekly follow-up would be a good one.
You've done a 2 weekly follow-up. You're going to do, see, a growth scan cannot be done in less than 3 weeks. You can repeat the Doppler, yes, but you cannot repeat the growth assessment every 2 weeks. That has to have a minimum of 3 weeks of interval. Okay, so now you have followed her up. Now she has come to 38 weeks. Yes, Dr. Meenakshi?
No, ma'am. I'm listening.
Ma'am, this is Dr. Priya, ma'am. Actually, I wanted to also enlighten, like in follow-up of the case, when we are following through the sonography, we also need to see for the clinical parameters, like whether there's any evidence of upcoming hypertension or the sugar profile of the patient. The past history can be taken into consideration, and we can have a good connect with the Doppler findings to have a sequential follow-up in this case.
Now, this is a very simple, basic case that I just brought up so that we could revise ourselves. So now she has reached 38 weeks. She's 38 weeks. She's still at the 10th centile and Dopplers are normal. So when do you want to deliver this patient? 38 weeks, 39 weeks, 40 weeks, more than 40 weeks.
38 weeks.
Madam, if the growth interval is correct and the the Dopplers are normal and there is no other pressing reason for delivering, then ma'am, I feel it still comes in the bracket of SG only still. So then unnecessarily inducing a patient at 38 weeks, I don't know. It also depends upon her cervical score. If she's into labor, then fine. But then unnecessarily.
No, she's not in labor. Now, see, you as her obstetrician, she's asking you that my baby is 10%. So, when do you think I need to deliver? Patients will ask you weird things, no?
Yes, ma'am. If she herself is a
Ma'am, we should wait for a spontaneous onset of labor.
Yes.
We should assess the liker of the
everything is normal except that the growth is at the 10th centile.
The biophysical profile is normal, then wait for spontaneous onset of labor.
Okay. So
yes, agreed.
So, is there any caution? The baby is a little small. Is there any caution in the process of delivery? What is your consideration about a vacuum or a forceps if needed?
No.
Any baby.
Dr. Jadhav, sir?
We should actually tell option of slowly delivering the baby, first of all, and it should be assisted delivery. Also, we should stop a little for the blood from the placenta to reach the baby. So delayed cord clamping should be done in this case. And slow delivery of fetus should be done because the fetus is more fragile and sensitive to external actions. So that may be practiced.
Okay. And do you expect any perinatal complications to the baby just because it is small?
Yeah, perinatal complications we do suspect. But if at all, while doing a cesarean section, if we have given and more than 38 weeks with good weight, with good responses, may not be suspected. But maybe there can be chances of TTPM, transient tachypnea of newborn, or sometimes there can be delayed cry. So this can be there, ma'am.
Okay. Anybody wants to add anything here? So this
And
case,
these babies
we
are prone.
proceed to the next.
Hello.
Anyone
Some
wants to add
chances of intranatal asphyxias are also more in these babies, and as per the literature, those babies who are SGA, they are more prone to be get this stillbirth. If we look upon the literature, they are more labile.
Yes. So
Ma'am,
you
we can
are
also
going to
follow
have a
the
CTG.
Ma'am, such
Yeah,
babies
have
are
a
sometimes prone for the developmental delay, like their babies, they need to have a close follow-up in the initial perinatal period to assess the growth further post-delivery. So perinatal delay in the growth development may be there.
And hypothermia may be there also.
Yes.
Because weight is very less.
Agreed. So we are done with one case where if it is SGA, you're going to wait for normal delivery, cesarean only for obstetric indications.
Yes.
Right?
Yeah.
And you're going to have a slow delivery. You don't want precipitate labor. And then the child has to be kept warm and handed over to the pediatrician. Now you have the second case. She's a Gravida 3, Para 1, Abortion 1. She's 34 years old. And sonography was done at 34 weeks. She has not brought any reports. Now, both the renal pelvis were dilated, calyces were also dilated. Liquor was adequate. Maximum vertical pocket was 5 centimeters. No other anomaly was detected. So, what is your differential diagnosis? What do you think this could be?
It could be a
Posterior lateral wall since
posterior.
bilateral pelvis is dilated.
Yeah. Bilateral pelvis is dilated. Purvi, we need your help here.
Yes, ma'am. So the first and the most common cause is a constitutional dilatation, that is because of the pregnancy maternal progesterone effects. The second thing, because this lady has not brought her prior reports, and we all know that renal pelvic dilatation is a marker for T21, we might want to check that up and urge her to bring her old reports if at all an anomaly scan had another markers, any a screening for first trimester, for T21 has been done or not. Third thing, differential of hydronephrosis. The cutoff in the third trimester is 7 mm, and more than 15 mm usually indicates a postnatal requirement for surgery. The thickness of cortices also is important, which is missing in this report, which can also tell us about the persistence of postnatal hydronephrosis. And then lastly, as ma'am told, lower urinary tract obstruction in male PUV, and also obstruction, vesicoureteral reflex also can be. So we need to see the AFI, the ureter, the bladder, everything.
The maximum vertical pocket was 5 centimeters. Nothing else was found. The cortex was fine. So now, how are you going to manage this case? She is 34 weeks. Are you going to panic? What are you going to say to the patient?
We can have subsequent scans to monitor the renal pelvis dilatation. And because the liquor was adequate at 34 weeks, so we need not panic, because whenever it is associated with the major abnormalities or the major grievances, then it would have been an oligo part. But the liquor here is adequate, so this is the best guide. We can simply follow the renal pelvis diameter in our subsequent scans, and we can just counsel the patients that we may need to have an assistance once the baby is born. We can have the postnatal USG done for the kidney assessment, and accordingly the management can be taken care of.
My basic question here to save our own skin. Do you want the patient to consult a neonatal urologist?
Yes, ma'am.
Yes.
I'm just reminding that, this is something we need to take care of. Don't always take unilateral decisions. You need to, pull as many people as possible into your boat, because if something goes wrong, it's going to be on your head. Now, this pelvis is dilated. It's 12 mm and it remains 12 mm. Now, when are you going to deliver her?
At term. At term, she is
At
34.
38.
Somebody said 38. May I know who said it?
I'm Dr. Meenakshi here.
Yes, Dr. Meenakshi. Why 38?
After steroid cover, we will deliver her at
No, she is
38.
already 34. She is gone beyond the time of steroid. So why do you want to deliver her at 38? Means that renal pelvis is not an indication for anything. You just follow up. If the liquor remains adequate, let her deliver as she would deliver. And perinatally, you have to send her to the pediatrician and the
Pediatric
urologist.
urologist.
Okay.
Okay.
I had a patient who had very bad hydronephrosis like this, 10, 12 mm, ureters dilated, bladder dilated. But once she delivered, everything disappeared. It was a male child and everything disappeared. We could see nothing postnatally. So, as sir was saying, Dr. Lulla sir, that changes keep taking place. The fetus is constantly growing. So we just follow up and we don't panic the patient, but we take all help that we can. Yes, anybody
Madam,
want to add something?
yes,
Yes,
ma'am, Dr. Lakshmi here.
Yes,
I
Dr.
had this particular same type of a case was there. We have a debate whether we are complications should maternal complications should decide whether the scanning should be done in the third trimester or not. This lady totally had no complications at all. Her only plus point was that she was increasing weight. The weight of the patient was increasing. She was a tall patient, hefty patient. We did a scan at around 34 weeks, and bilateral renal pelvis was dilated around like 3 centimeters, 30 millimeters. One was 4 and one was 3, I think so. The baby had ascites, fetal ascites. And as we stay in a little bit far away area from the city, so the patient did not take it so seriously and went to the concerned tertiary center only after 2 days. When 2 days later the baby reached there, the baby was in failure. And they delivered the baby. The baby is doing fine right now. It was a posterior urethral wall.
Okay.
Just one input, ma'am. Actually, if any other complication is there, then only we should go in mild to moderate renal pyelectasis. But like we have seen that only postnatally we send to a urologist. They do a scan. If anteroposterior renal calyceal diameter is less than 10, they don't bother. Only 4 to 6 weeks they will follow for 3 times again. And if it is fine, then they will keep. But there is renal pyelectasis is not an indication to deliver earlier.
Thank you, sir. So now we proceed to the third case. We are doing really fine and we have 4 more to go. This is a Gravida 3 Para 0 2 abortions. She is 38 years old. She failed her IVF and then she conceived spontaneously. We've all seen this happening. And because she had gone to some, somebody who said, don't get an examination till 28 weeks, she has come at 28 weeks. They tie a thread, they say certain things, and these people will follow. Now we see that this is a case of twins. There are 2 babies. So what do you want to see? It's a case of twins. What do you want to see? It's 28 weeks and it's twins.
Chorionicity and the weight difference.
Correct. So you want to see the chorionicity and amnionicity. Is it easy to see that the chorionicity at 28 weeks?
It's not so
Ideally, after 14 weeks, there is a fusion between the amnion and chorion. So it becomes really difficult. And as far as the placental masses is concerned, even in a dichorionic ones, the placentas are lying so close, it is very difficult to have a real good judgment. You need a real expertise for detection at 28 weeks, ma'am.
So then you need to first send to an expert. That is
I
one.
feel so, madam.
So now you have checked for the chorionicity and amnionicity. So how are you going to judge when you are seeing, if you see a membrane in between, it's obviously diamniotic.
Diamniotic.
Okay. And then you follow that membrane to the edge, and there you are going to see
the
what kind of shape it is, whether it is a lambda or it is a T.
Lambda or T.
Okay. So if it is a T, it is monochorionic.
T is monochorionic.
And if it is a lambda, it's
a
dichorionic.
Dichorionic.
Lambda is a bit of placental tissue in between both the amniotic membranes. Now, she hasn't been seen before. Would you want to do a detailed anomaly scan?
Definitely.
Yes.
Yes. So, who's doing their own scans? Anyone in the panel who's doing their own scans? Dr. Lakshmi, you're doing them?
Yeah, ma'am.
So, would you just enumerate one by one what are the planes that you're going through? When you're doing the anatomy scan.
Yeah. Ma'am, the 5th month TIFA I'm not doing. I was talking about this 28 weeker scan.
But here she needs a anatomy
Anomaly.
scan.
Yeah,
Right.
anomaly. I would definitely send it somewhere else, but then rest all scans I'm doing. So I just enumerate.
Yeah. So actually here what we are seeing is that you need to do a detailed anomaly scan.
Yes.
Twins is anyways more difficult.
Yes.
Right.
So,
because kids keep moving and they keep merging into each other and it becomes a bit tough. Purvi, would you like to just tell us?
Yes, ma'am. So, as sir told, every opportunity of a scan must be considered as an anomaly scan, and more so in this patient because there were no previous scans done at all. So, because it is a twin, first type of twin chorionicity. If we cannot judge the chorionicity, we should always take it as a monochorionic twin. We should anticipate the complications associated with monochorionic twins. Second, the position, the Likert, the Doppler, the bladder, and the anatomy. In anatomy, we usually, when we have singleton 5th month, we start from head to toe and also position dependent, front to back, the Dopplers, the cervical length, the placental position, the cord attachment, and the Likert. So if you go from head to toe, the head, in the head, you see the CSP, the lateral ventricles, the falx, the thalamus, the cerebellum, the posterior
You
fossa.
would take 3 views of the head, then you go to the neck, then you take 4 views of the heart.
Yes, the thorax,
the
the diaphragm.
situs and the situs, the thorax, and then the both outflow tracts, 4 chamber.
Right.
Right.
Then continuing with the situs, the stomach, the umbilical vein, the cord attachment, the entire intestine, because it is 28 week, we might grab on that opportunity. The bladder, 3 vessel view, and the limbs to the extent we can see because it is a twin.
And at least the sacral portion of the cord is what you want to see. The thoracic spine and the
cord attach, cord insertion.
No, the sacral spinal cord.
The tapering of the cord, yes.
The tapering of the cord that you want to see.
Yes.
You also want to rule out any small encephalocele in the head. So these are the basic things that you're going to see. Now you
also one.
Yes, ma'am.
Sorry, ma'am.
Yeah,
no,
go ahead,
no. One thing which we always follow in twins is that usually what happens, we mistake one limb for the another child. That's what happens usually because the head and all everything is jumbled up in the abdomen. So usually what I do is once I see the head of a fetus, I just follow that spine of that same baby so that I'm sure that it's the same baby which I am measuring.
and I'm not measuring the opposite femur length and this child's abdominal circumference, then the weight will all get mixed up. So I follow the spine of the child, and then I take the head of the another baby and then follow the spine of that child.
So that's a very good point. And then how are you going to, you've done the anatomy, it's normal. So now what is your follow-up plan? When do you want to call her next? She's at 28 weeks. You are her obstetrician. When are you calling her next?
Since
Mostly
this is
on
a okay, ma'am, somebody else.
4 weeks, ma'am, we will call and we will see for if any discordance is there. If it is more than 20%, then between the both fetus, then might be like the growth is not proper according for the both fetuses. So mostly after 4 weeks, I will call, see for the internal growth, see for any if the yes, ma'am. I think Lakshmi ma'am wants to say.
No, you finish. After that, I'll talk.
So we will follow up after 4 weeks, ma'am, for this patient.
Yes,
I would like to call her after 15 days.
15 days.
Yes, ma'am. Because she's 38 years, she's a high risk
Yes.
pregnancy. She has
And she's
IVF pregnancy
twins.
has been lost, and she has not come till now. And she's a twin pregnancy. So there are 3 risk factors here. So that's why just means for our sake, we will call for 15 days. Even if everything is normal.
What Purvi said was that if you cannot assess, it is monochorionic. And
Yes.
the guideline is in monochorionic, you have to call every 15 days. Simple. She's 38. She's likely to get PIH and all also.
Yeah.
GDM, PIH, and all that. She's already 28 weeks. So we need to assess her as though she is monochorionic. And what are the factors that will help you decide what is going to be her mode of delivery?
Are maternal factor, fetal factors?
The weight of the babies, the presentation of the child.
Ma'am, the
Like
cervical length is very important when it comes to a twin IVF pregnancy because she is presented at 28
She
weeks.
is not, she's not IVF. She had IVF done.
Sorry, failed
failed.
IVF. Yeah, I got it, ma'am. Ma'am, ideally the twin pregnancy, because it carries a risk for preterm delivery. So we have to really assess the cervical length. If it is less than 2.5 mm, we have to keep an eye on that cervical length monitoring to see whether the patient is going into preterm. We have to counsel the couple there and then, and if required, the impending preterm delivery is about to happen, we need to shift them to a proper maternal fetal medicine care center where the preterms can be handled properly. So that time factor is equally important when it comes to delivery in a case of twin.
Okay. Okay. So we've done with that. Now this is another case number 4, Gravida 2 Para 1, 1 cesarean 7 years back. She's now 36 years old. Presenting at 32 weeks and her AFI is 24. The maximum vertical pocket is 12. The fetal weight is at the 98th centile. Dopplers are normal. What do you suspect in this patient?
She is case of
Gestational
gestational.
chorioidomness stands for gestational age.
Dr. Jadhav, you were saying something?
Actually,
diabetes.
she has polyhydramnios with macrosomia, so we are mostly suspecting gestational diabetes mellitus in her. So we'll confirm that if she is having gestational diabetes mellitus or not.
So how
most
will
of
you
the-
confirm? What is your process?
So we will advise her for doing 100-gram
Oral
GTT and also HbA1c, and then we can see
Actually,
if
that is why I put this purposely, because are we doing a DIPSI or are we doing an OGTT? What is the practice?
Actually, OGTT is standard. DIPSI is there for centers which are not having good compliance to patients, in which we are giving.
No, Government of India has make it a DIPSI. Has to be done. 75-gram glucose tolerance test.
Yeah.
Yes.
We are
Yeah,
doing
but
that.
actually OGTT is a better indicator with 4 sugar values, fasting 1 hour, 2 hour, and 3 hour with 100 gram.
Nowadays,
So I
ma'am, the
do prefer.
guidelines say that it is mandatory to do 75-gram glucose challenge at 24-26 week of gestation to screen for the risk of GDM.
She's 32 weeks, no?
Yeah, here it is. She's
32
32 weeks, and in this case, we can go for direct fasting blood sugar. Then we can
And
get a
yeah,
PP. Yeah,
timed blood sugars
timed
are
sugar.
better, right? With
Yeah, they are
HbA1c.
much better than getting
Can do a sugar
GPP
profile
or
also.
a glucose challenge
Yeah.
done, because there are already two risk factors, macrosomia and the poly. So it's good to go for.
Now she's
Full
already
sugar.
32 weeks. She is GDM. We have confirmed it. You want to put her on insulin or you don't want to put her on insulin? She
We'll put
has macrosomia and polyhydramnios. So two things have to be managed. Her sugar has to be managed and that polyhydramnios has to be managed.
So we'll prefer insulin because stringent control is there with insulin. So that way we'll have a CGM if at all it is available in the centers. And with that we can titrate insulin dosages far more finely so that we may be in capacity to decrease the sugars and then control in a view polyhydramnios complications.
Dr. Purvi?
Yes, ma'am.
When would you want to do drainage of some fluid? When do you want to remove some liquor?
I would only insert a needle through her uterus when the mother is having complications due to the enlarged uterus. So usually when it crosses 30 is when we anticipate the mother having pressure symptoms. Once she has pressure symptoms only and only then I would like to put a needle, because she's diabetic, she might have more chances of chorioamnitis. And if at all, she's already 32 weeks, if at all we pull without an invasive procedure, it is always better.
So that was the point, that unless mother has symptoms, we are doing nothing. We are just managing her sugar. We are not managing her polyhydramnios. So how many weeks do you want to carry this pregnancy? She's 32 weeks. And when do you want to deliver her?
Ma'am, basically
beyond
depends
38.
upon her sugar control.
Not beyond 38, madam. I mean, with good control, of course.
Ma'am, we can
Even
also have
ACOG
a
has
third.
said if she's well controlled, so we should wait till 40 weeks.
See, do you think this is a well-controlled patient?
This is
No,
not a
ma'am.
Not at all. Not at all.
Definitely
Let us
at
talk about this
37
case.
weeks.
When do
Actually,
you want to deliver her?
Post 37 weeks.
37.
Post with 37 weeks should plan for a section because she might be a macrosomic and weight may be larger. So normal
Plus
delivery is
IUFD
also
chances
not
are.
possible, and there are chances of sudden IUD due to this polyhydramnios and gestational diabetes. So it's always better to deliver after 37 weeks because macrosomic babies post 38 weeks may be more than 4.5 kgs also. And sudden IUD chances are also there, so it's better
Everybody
post-maturity.
agrees that you're going to do a cesarean?
Ma'am, a Doppler monitoring should be done even when the patient
Previous
reported
cesarean
at 32 weeks and we got to know that she is having diabetes undiagnosed till 32. A
Dopplers are
Doppler
going to be
monitoring.
done. Her Dopplers were normal.
Ma'am, already she's previous cesarean section and she's
Yes.
36 years old.
And when the scar thickness also has to be taken into account because she is into polyhydramnios, a big baby, previous section, the reduced scar thickness may lead to impending dehiscence, which may be the criteria for the delivery.
In this case, I would like to deliver her at 36, which is ideal at this time. Now, do you expect any problem in the fetus, perinatal problems?
Yes, ma'am. Actually, the baby is bound to have hypoglycemic attacks. So we actually recommend that they stay in NIC for 2 days until the sugar control of the baby is regained.
Such babies are more prone for infections, for respiratory complications.
Hypoglycemia, hypocalcemia.
Calcemia.
Okay. So that has to be managed. Now we proceed to the fifth case. Are you people finding it boring or should I go on?
Ma'am, you should go on. I think you
go on.
No, it's very nice,
so
ma'am.
good, ma'am. Ma'am, it's very nice and interactive and we are learning mutually.
A lot, actually. Yeah.
So it's a Gravida 3 Para 2 living one. She has 2 cesarean sections, but only 1 living child. She's at 32 weeks. She is 28 years old with no maternal complication at present, and she's presenting for scan. The growth is at 60th centile. There is no anomaly. Liquor is normal. Placenta is anterior, low lying. and 0.96 centimeters from the os. How should this scan to evaluate the placenta be done?
Vaginally.
Vaginal sonography.
Transvaginally.
Yes.
Ma'am,
Transvaginally and
Partially filled bladder.
that is a very important point. It has to be a partially filled bladder. It cannot be an over-distended bladder. It cannot be an empty bladder.
Empty bladder.
And it has to be with Dopplers. Okay. A transvaginal scan with Doppler, with partially full bladder. And what do you expect to see?
Placenta abrupta syndrome can be suspected on these cases.
So what are the findings that you would see in any case where the placenta is morbidly adherent? What are the things that you would see?
And loss
can see
of
that the plane
Loss of
means
bladder and the myometrial interface, and there is a vascularity over the bladder and myometrial interface. That might be
in the placental mass.
Dr. Jadhav, what
the
about the placental lakes?
placental lakes may be seen, and actually, ma'am, the plane of differentiation is not seen clearly between the planes. Ideally, for this kind of, I will prefer a linear probe. Linear probe that should be
When
like
you're doing transvaginally, how do you put in a linear probe? You're doing it transvaginally, right?
Yeah, we do it transvaginally also, and also on abdominally we can put a linear probe to see the proper thickness of the walls and the planes separating. So both ways we can judge if it is accreta, increta, percreta, or where the planes are lying. So placental lakes and plane of differentiation can tell us better.
So you would see turbulence in the myometrial thickness will be thin. You will see blood vessels crossing between the bladder and the myometrium. So that is the biggest thing that you are afraid of, and you would actually prepare yourself for a problem in cesarean. So either you're going to do it yourself or you're going to refer to a higher center.
If the facility is available at your center, we can go for this.
Tertiary
Otherwise,
center,
we should send the patient to
always
the higher
better.
center for the management.
Okay. So do you want to arrange blood for this? Do you want
Yes.
any extra consent?
Try to take
any extra consent? Do you want another
Hysterectomy,
year?
on-table hysterectomy.
Consent of hysterectomy.
I would rather
Blood
go for
trans-
a MRI to be done in this case to confirm my findings.
Yes.
And after that, place where cath lab is there, where we can do uterine artery embolization, I would prefer doing cesarean section at that place with bloods arranged.
Okay. Okay. So,
but consent should always be taken if there is a PS, spectrum is there. Consent should always be taken for a hysterectomy, just in case. Like we are not going to do for every case, but at least that much.
yes.
Always prepare
Would
patient.
you always think of a hysterectomy?
No.
No, not every
Not at all.
time, but that might be a possibility during cesarean section. We should
uterine artery embolization is a better option.
As sir said, uterine artery embolization is a very good procedure. It does take care of things.
Ma'am, sometimes it's a focal accreta, not the generalized one. That also can be taken into account. We can leave that part of placenta and the rest can be managed. So sometimes it's a focal presentation also.
Okay. So that is an important point, that just because there is some adherence, you would not always consider that you have to remove the whole uterus. Now we come to the last case, and this is a gravida 2 para 131 years. She has one vaginal delivery 5 years back. She's come at 36 weeks for a scan. It's a frank breech. Growth is appropriate. Placenta is posterior. Lower uterine segment is empty except for feet. Liquor is adequate. Does this scenario alert to any complication?
Cord prolapse. If she goes into labor, there might be possibility of cord prolapse.
cord prolapse. And now you have, how can you avoid cord prolapse?
At she's 36 weeks, we can admit the patient at the center and the planned accordingly.
See, she has one vaginal delivery 5 years back.
Yeah.
And try.
Do you think she's going to agree कि वो 4 weeks पहले आपके पास hospitalize हो जाए? She would not be hospitalized 4 weeks early.
We should explain the complication which can be arises because of this clinical scenario, and she should be taken care of this, and we should follow up every weekly.
Now you've done a scan, and now you're also seeing that the placental lower edge is giving rise to the cord, and it is vasa previa. Now what are you going to do?
Elective cesarean section.
At how many weeks?
13.
The moment she's term 36, if she's 36, I'll
She
deliver
has
her.
come to you at 36 weeks. And
I'll deliver, madam. The risk is too much.
Ma'am, before the patient goes into active labor, we can think of delivering the patient through C-section.
Just in case she goes into labor at home, then she'll lose the child.
So you will explain everything and you want to do a cesarean section. Is that right?
Now she's 36 weeks. Now she's 36 weeks and she diagnosed vasa previa. Then we can plan for elective cesarean section in these cases after admission.
Immediately or later?
At least, ma'am, 37 weeks we should wait for the planning of the cesarean section.
Who agrees to wait a week and who says we should go ahead now?
And
Go
wait
ahead
for
now.
a week.
Go ahead now, ma'am.
Go ahead now, ma'am.
Yeah, I have
Because
seen a
we are
vasa
going to
previa. It
call
just
them.
died in front of our eyes. Means
It's very difficult once the bleeding starts, ma'am. So it's better to go now because 36 weeks majority is already there. So we
yes,
need
and
to
we
assess
can
the in
manage the
utero
child
versus
anyhow.
postnatal. Yeah.
Would
It's
you
too much of a
ask
risk.
her when she had her first delivery, whether it was full term or whether it was?
Yes.
Yes. That may, but ma'am, the present scenario, like being 36 weeks, she's more of, and the vasa previa, I think that is the best time to get delivered.
She's already 36 weeks and she's
Yeah.
safe and she's sound and she's come.
It's a safe gestational size. So rather than waiting for the complications, we should go for impending delivery, urgent delivery.
After explaining all the
Your
complication of
hand
preterm
is up.
delivery.
You want to say something? Dr. Khushbu?
Ma'am, after explaining all the complication of the prematurity in preterm delivery, we can go ahead with the cesarean section with the due consent of the patient.
Okay. So I think we've had a nice time and we all agree that a third trimester scan should be done.
Yes.
Yes, ma'am.
Yeah.
And it should be done well. We should evaluate the placenta and the membranes and the whole baby. And as obstetricians, also the presentation and position if the patient has come near to term. Right?
Yes, ma'am.
Now, I would like one take-home message from each one of you before we end the session. And before I actually do that, please nominate me. Please.
Sure, ma'am.
100%.
So,
best wishes from our side, ma'am.
Thank you, dear. Thank you. Khushbu, Dr. Khushbu?
Yes, ma'am.
Boliye. You are the first one. On my screen, you are the first one. So, one take-home message from you.
She has the today's session on the discussion of the third trimester ultrasound scan. We should go for the third trimester scan with very precise way before leaving this Zoom meeting, and we should take care of the all the anomalies and Leica and the presentation and the sonography for the better explanation of the further outcome of the pregnancy.
Priya? Okay, you go next, Lakshmi. Go. Come on.
In case we come across any fetal anomaly, like either newly detected or old already is there, a very good take-home message is that we should involve the pediatrician or the future pediatric surgeon of the child. Let the patients and the bystanders go to that person, discuss the problem, because they'll be able to explain it much better to them, and then have a proper plan delivery.
Okay.
Ma'am, if any of the problem is encountered in the third trimester scan, the same day thorough counseling and information to the couple should be done along with the relatives, and timely referral to the higher center if mandatory. This is my side take-home message, ma'am. Same day is really important.
Okay. Neha? You're muted.
Kindly unmute,
Yes, ma'am.
Neha.
Third trimester scan should be done, and the timing should always be individualized as per the patient's condition, depending upon any other associated risk factors.
Dr. Jadhav?
Ma'am, regarding one take-home message is that third trimester scan is usually done casually, which should not be done. There should be high amount of suspicion regarding each and everything, regarding the Leica, Dopplers, or the placental position, which may actually give us an indication of when to aptly deliver and to save mother and child. If at all you are not in capacity or suspecting, or your machine is not capable, send to a fetal medicine expert, but save mother and save child from any complication.
Thank you, sir. Dr. Meenakshi?
Hello.
Yes, Dr. Meenakshi.
Ma'am, always a decision should be taken not only on the ultrasound findings, it should be correlated clinically and counsel with the patient.
Okay. Okay. Purvi? Dr. Purvi? Dr. Purvi?
Yes,
Dr.
ma'am. My take-home message will... Yes, ma'am. Can you hear me?
Yes, go ahead. Yes. We would also like to see you once.
Yes. My message is every scan should be an anomaly scan, either first, second, or third trimester. Every growth scan should be a Doppler scan. I would prepare for the worst and hope for the best.
Okay. Okay. We really want to see you, Purvi. Dr. Chandarlulla, sir, you are here? There. That's Purvi, a fetal medicine specialist from Dr. Adi Makam Center. Now she's practicing in Raipur. So, Dr. Chandar, sir? No. Mehul? I thank
Yes, ma'am.
all of you.
Yes, ma'am.
I thank all of you for being here,
you, ma'am.
taking your precious time.
Thank you, ma'am. Thank you.
And on such a topic where people fear to tread, we don't do ultrasound, it doesn't concern us, but we deal with the results of that ultrasound. And therefore, we should be aware of what is going on. So thank you so much from the bottom of my heart for participating and interacting and helping me learn more. Thank you so much.
Thank you so much,
Meet
ma'am,
you
for
again
Thank you,
giving
ma'am.
next
all
week,
of us the opportunity
Wednesday,
to come.
5 p.m. with primary amenorrhea as our topic. We'll be taking,
Wonderful,
we have great speakers. Dr. Suvarna ma'am will be speaking on the etiology, and Dr. Hafiz Rahman will be demonstrating lap surgeries for primary amenorrhea. So I welcome all of you to that session, and I thank all of you, all the viewers and Corona Remedies for being our academic partners.
Ma'am, it's a request.
Yes, please.
Ma'am, one more session about menopause and postmenopausal therapies.
We did one session on postmenopausal therapy. I'll share the link with you, and we will do it again sometime later. But it's not been too long since we did it. I'll
Yes.
share the link with you. That went well as
Thank
well.
you.
So thank you so much.
Thank you, ma'am. Thank you.
Thank
So
you.
thank you so much,
Bye.
Asha ma'am.
Thank you so much,
It was
ma'am.
wonderful. You have given so much of your time, and it was wonderful. The whole of the Quota Society is with you. And thank you for involving us, and best wishes for your elections.
Thank you.
Thank you.
Thank you, ma'am.
Thank you, everyone. It was great interacting with you all.
Thank you, everybody. Thank you from
Thank you,
Kerala.
ma'am.
Kerala.
Bye, ma'am.
Bye.
Mehul, you may end the session, please. Lakshmi, Dr. Lakshmi, you're very sweet.
Yeah, thank you, ma'am. Thanks a lot. Same as you. I'm from Bombay only. I've been
Okay.
settled here. Yes.
Okay.
So I've been settled here. Okay, see you.